Welcome back to Med School Radio. This is Simon, and we are going to be looking at Lang, biochemistry, and genetics flashcards. This time we're focusing on carbohydrate metabolism. So, as I said before, I'm going to repeat it just so that we know what we're going to be looking at. The general concepts we'll be looking at will be glycogenesis, glycogenolysis, glycolysis, regulation of gluconeogenesis and glycolysis by fructose 2,6-biphosphate, bisphosphate, glucokinase, Looks like we have some more people coming to join the party. I'm living in a hospital, so that's why you hear that sound. Anyway. Okay, so as I was saying, regulation of gluconeogenesis and glycolysis by fructose 2,6-bisphosphate, glucokinase versus hexokinase, pyruvate metabolism, pentose phosphate pathway, fructose metabolism, polyol pathway, galactose metabolism, lactose metabolism, gluconeogenesis, and the Quarry cycle. The diseases we'll be covering, specifically, the glycogen storage diseases, von Kerke disease, Pompe disease, Quarry disease, Mcardle disease, liver phosphorylase deficiency, Anderson disease, Tari disease, Pyruvate dehydrogenase complex deficiency, glucose 6-phosphate dehydrogenase deficiency, and disorders of fructose metabolism. We'll be looking at essential fructosuria, fructose intolerance, and disorders of the galactose metabolism, classic galactosemia, galactokinase deficiency, and as for disorders of lactose metabolism, we'll be looking at lactase deficiency. So let's go ahead and look at the first card, which will be von Kerke disease. Okay, so here's the case. A 3-year-old boy is brought to a pediatric clinic because of restlessness and fatigue. The mother is concerned that he becomes fidgety between meals. On physical examination, you notice that the child has very fat cheeks, making his face appear dull-like, and his abdomen is quite protuberant. The boy is short for his age, and his arms and legs are thin in comparison to his trunk. You order a series of laboratory studies expecting to find marked hypoglycemia, elevated serum uric acid, and elevated serum lipids. If your hypothesis is correct, you believe that the child will benefit from frequent meals with cornstarch supplementation and restriction of fructose and galactose in his diet. So the biochemical defect here is an autosomal recessive disorder that results in a defective glucose 6-phosphatase enzyme in the liver, kidney, and intestinal mucosa. Pathophysiology. Glucose 6-phosphatase is required for conversion of G6P into glucose during gluconeogenesis. Defective glucose 6-phosphatase results in the buildup of G6P, thereby resulting in accumulation of structurally normal glycogen in the liver and kidney, leading to hepatomegaly. Patients are also deficient in the production of glucose from gluconeogenesis and thus become susceptible to fasting hypoglycemia, resulting from glucose deficiency. Now the clinical manifestations. Affected patients with von Kerke disease present at 3 to 4 months of age with hepatomegaly or hypoglycemia. Patients often have dull light faces, which is fat cheeks, thin extremities, short stature, and a protuberant abdomen resulting from hepatomegaly. The lab findings would be hypoglycemia, lactic acidosis, hyperuricemia, and Okay, the treatment. Continuous nasogastric infusion of glucose or oral administration of cornstarch. Restricted dietary intake of fructose and galactose because these molecules cannot be converted to glucose. And dietary supplements of multivitamins and calcium. And lastly, allopurinol to lower the levels of uric acid. Now the notes here. The hepatic glycogen storage diseases that are characterized by hepatomegaly and hypoglycemia include von Gerke type 1, as well as liver phosphorylase deficiency, HERS disease, this is HERS disease, type 6, and phosphorylase kinase deficiency, which is type 9. Take a short break here. Okay, and the next card we're going to look at is Pompe Disease, type 3. So first let's look at the case. A 3-month-old girl is brought to your pediatric clinic. One moment. Because she is not feeling well and has poor weight gain. On physical examination, you find that she has a large tongue and mild hepatomegaly. She is also significantly flaccid and hypotonic. Fearing an autosomal recessive glycogen storage disease, you order an ECG, which shows a short PR interval and a wide QRS interval. You order a series of serum studies expecting to see elevated creatinine kinase, aspartate transaminase, and lactate dehydrogenase. You fear that the child has a poor prognosis and will likely suffer cardiopulmonary failure and death before her first birthday. This is Pompe disease. The biochemical defect here is an autosomal recessive disorder caused by a deficiency of lysosomal acid alpha-1 4-glucosidase. The pathophysiology. Lysosomal acid alpha-1 4-glucosidase, this is acid maltase. It is an enzyme responsible for the degradation of glycogen in lysosomal vacuoles. If lysosomal acid alpha-1 4-glucosidase is defective, there is resulting accumulation of lysosomal glycogen in the skeletal muscle, cardiac muscle, liver, and kidneys, which leads to myopathies, cardiomyopathy, and hepatic dysfunction. As for the clinical manifestations, there are several forms of Pompe disease. In the infantile onset disease, which is the most severe, patients present with hypertrophic cardiomyopathy, hypotonia and myopathy, failure to thrive, macroglossia, which is a large tongue, and hepatomegaly. Death occurs by 1 year of age. The juvenile form typically presents as delayed motor milestones and difficulty in walking, followed by swallowing difficulties and proximal muscle weakness with death by the 3rd decade. The adult form presents as a slowly progressive proximal muscle weakness with truncal involvement. There is no cardiac involvement in the juvenile or adult form. The lab findings show elevated serum creatinine kinase, elevated aspartate transaminase, elevated lactate dehydrogenase, and the muscle biopsy shows vacuoles staining positively for glycogen. For the treatment, there is no effective treatment for the infantile form, and high protein diet is needed for the juvenile and adult forms, and ventilatory support is needed. Now, for the notes, it lists here that the other glycogenesis diseases are characterized by cytoplasmic accumulation of glycogen, whereas Pompe disease is the only glycogenesis disease that is characterized by lysosomal accumulation of glycogen. So I hope that you caught that, and I will now prepare the next card. The next card we'll be looking at is Quarry Disease Type 3. A 7-year-old boy presents to your pediatric clinic complaining of muscle weakness of 1-year duration. His parents are concerned because he gets tired very quickly when playing with his classmates in the yard. He is an only child and his mother's pregnancy was full term with no complications. On physical examination, you note that he has moderate hepatosplenomegaly, is of short stature, and has marked muscle wasting. At his last clinic visit, serum studies revealed hypoglycemia, hyperlipidemia, a fasting ketosis, and elevated liver transaminases. You consider the possibility of a glycogen storage disease and suggest a high carbohydrate, high protein diet while awaiting definitive DNA-based analyses. So this is Quarry disease. The biochemical defect, an autosomal recessive disorder that is caused by a deficiency of glycogen debranching enzyme alpha-1,6-glucosidase. As for the pathophysiology, glycogen debranching enzyme is an enzyme that aids in glycogen degradation by breaking the alpha-1,6 bonds. When this debranching enzyme is defective, glycogen breakdown is incomplete, and abnormal glycogen with short outer chains accumulates in the liver and muscle, leading to hepatomegaly. Hypoglycemia results from ineffective glycogen breakdown. The gluconeogenesis pathway is not affected by this disorder. Now the clinical manifestations. Patients of Quarry disease will present with hepatosplenomegaly, hypoglycemia, hyperlipidemia, and growth retardation. Other symptoms include short stature, skeletal myopathy, which is progressive muscle wasting, and cardiomyopathy. Hepatomegaly improves with age and disappears after puberty. The clinical manifestations are those, but also of the lab findings, there's hypoglycemia, hyperlipidemia, elevated liver enzymes in childhood, and fasting ketosis. The treatment for Quarry disease is high carbohydrate meals with cornstarch or nocturnal gastric drip feedings for hypoglycemia, and high protein diet during the day plus overnight protein infusion for myopathy. And lastly, the notes here, Quarry disease is of high prevalence for non-Ashkenazi Jews of North African descent. Okay, take a little bit of a break here while I prepare the next card. Okay, continuing on. What card should we look at next? I'm just choosing some nice music here. I have a great playlist for study music. And we are listening to Debussy. Okay, here we go. Okay, the next card is Mcardle disease, type 5. A 22-year-old man presents to your ambulatory clinic complaining of painful muscle cramps when walking 8 flights of stairs to his new apartment. On further investigation, you learn that he also experiences the severe muscle cramps after lifting weights in the gym. On several occasions, he has had reddish-purple urine after exercising. You suspect that this patient may suffer from an autosomal recessive glycogen storage disease, and you obtain a serum sample to test for elevated serum creatinine kinase at rest. While awaiting the test results, you suggest that the patient avoid strenuous exercise and eat a high-protein diet. So now let's think of the details of this case. The biochemical defect, it is an autosomal recessive disorder caused by a deficiency of muscle glycogen phosphorylase. Now, the pathophysiology. Muscle glycogen phosphorylase is responsible for the breaking of the alpha 1,4 linkages of glycogen in muscle. Deficiency of muscle phosphorylase results in deficient glycogen breakdown, leading to glycogen accumulation in muscle. Without effective glycogen breakdown, the body has to use other means to generate ATP, often through the breakdown of muscle fibers, thereby resulting in eventual muscle degradation. The clinical manifestations of Mcardle disease: patients present in adulthood with exercise intolerance and muscle cramps. Symptoms are triggered by brief exercise of great intensity, for example, sprinting, or less intense but sustained activity, for example, climbing stairs. Half of the patients report burgundy-colored urine after exercise, myoglobinuria, as caused by muscle breakdown. The lab findings would be elevated serum creatinine kinase even at rest. And the treatment for Mcardle disease is to avoid strenuous exercise, augment exercise tolerance by aerobic training or by prior ingestion of glucose or sucrose. A high protein diet may increase exercise endurance. So that was Mcardle disease type 5. I hope that you are learning. I certainly am, just by reading these cards. Okay, I'm going to prepare the next card. Okay, the next card we're going to look at is liver phosphorylase deficiency, which is called, it's HERS disease, type 6. Liver phosphorylase deficiency. Okay, first the case. A 5-year-old girl is brought to your pediatric clinic for a routine physical. On examination, you notice that the child has not met her expected growth milestones. You also note evidence of hepatomegaly on examination. A series of initial laboratory studies reveal mild hypoglycemia, mildly elevated liver enzymes, and mild hyperlipidemia. You explain to the mother that you suspect that her daughter has a deficiency of a specific enzyme that is involved in glycogen metabolism, and you reassure her that this abnormality will likely resolve by puberty. So this is liver phosphorylase deficiency, or HERS disease, type 6. The biochemical defect, an autosomal recessive disorder that results in a defective glycogen phosphorylase enzyme in the liver. Pathophysiology. Glycogen phosphorylase acts to break down alpha 1,4 glycosidic bonds within molecules of glycogen, thereby resulting in the release of glycose 1-phosphate units, which are subsequently converted to G6P and entered into the glycolysis or glyconeogenesis pathway. Defective glycogen phosphorylase results in the failure to efficiently break down glycogen, thereby resulting in accumulation of glycogen in the liver, leading to hepatomegaly. Patients are also deficient in the production of glucose from gluconeogenesis and thus become susceptible to fasting hypoglycemia resulting from glucose deficiency. Clinically, the affected patients present in early childhood with hepatomegaly, mild hypoglycemia, and growth retardation. Patients often also have muscle weakness. Rarely, patients may have variants that involve neuropathy, myopathy, cirrhosis, or cardiomyopathy. The lab findings would be hypoglycemia, mildly elevated liver enzymes, and hyperlipidemia. The treatment and prognosis would be a high carbohydrate diet and frequent meals to avoid hypoglycemia. This disease usually takes a mild course, with most clinical and biochemical abnormalities resolving by adolescence. And the notes here on liver phosphorylase deficiency, or HERS disease: phosphorylase kinase B deficiency, formerly known as glycogen storage disease type 9 and 8, and C. AMP-dependent protein kinase deficiency, formerly known as glycogen storage disease type 10, are now included with glycogen storage disease type 6 and present similarly to type 6 disease. So there we have it. That was liver phosphorylase deficiency, or HERS disease. Okay, I'm going to prepare the next card. I wonder if you're catching any of these definitions. Are they memorable? I'm grouping them together to organize my mind, so I'm reading the Carbohydrate Metabolism cards from Lang, if you're just tuning in. And I'm doing this because I find that it organizes my mind and I'm able to concentrate on one category at a time. Okay, the next disease we're going to look at is Anderson disease type 4. So first let's read the case. An 8-month-old boy is brought to office by his parents, who are concerned that he is not feeding well. Examination reveals a listless child who is small for his age. You also notice an enlarged liver and spleen on abdominal examination, as well as an enlarged heart on chest X-ray. An electrocardiogram shows frequent premature ventricular contractions. When laboratory testing reveals a deficiency in the glycogen branching enzyme, you inform the parents that their son is afflicted with an autosomal recessive disorder of metabolism and recommend a consultation with a pediatric hepatologist. So that's the case of Anderson disease. So let's read about the details. The biochemical defect, firstly, an autosomal recessive disorder that is caused by a deficiency in the glycogen branching enzyme transglucosidase. The pathophysiology here is glycogen branching enzyme is an enzyme that aids in the production of glycogen. When this enzyme is defective, long unbranched glucose chains are formed and result in the deposition of this defective glycogen in the liver, heart, and nervous system. The clinical manifestations of Anderson disease: patients present in infancy with hepatosplenomegaly and failure to thrive. End organ damage can lead to liver failure and cirrhosis. There are some rare neuromuscular variants which present with muscle weakness and wasting. The lab findings are elevated liver enzymes in childhood. And lastly, the treatment and prognosis for Anderson disease: symptomatic treatment of liver failure, including possible liver transplantation. And the prognosis, unfortunately, is poor. Take a short break, and I'm preparing the next card. The next card we will discuss is Tari disease, type 7. Here is the case. A 6-year-old girl is brought to an urgent care clinic by her parents, complaining of severe muscle cramps in both legs after her weekly soccer game. Upon speaking further with the patient, you discover that she has been suffering from muscle cramps as well as nausea after every soccer practice for the last year. Her mother reports that the patient's urine is reddish in color and at times. When laboratory studies demonstrate evidence of hyperuricemia, hemolytic anemia, and elevated creatinine kinase levels, you begin to suspect that the patient may be suffering from a deficiency of an enzyme in the glycolysis pathway. This is Tari disease, type 7. The biochemical defect is an autosomal recessive disorder caused by a deficiency of muscle phosphofructokinase. Phosphofructokinase catalyzes the conversion of fructose 6-phosphate to fructose 1,6-diphosphate during glycolysis. When phosphofructokinase is absent, glycolysis is significantly impaired. So that was the pathophysiology, and now the clinical manifestations. Patients present in childhood with exercise intolerance and muscle cramps and weakness after exercise. Many patients report burgundy-colored urine after exercise, which is myoglobulinuria, as caused by muscle breakdown, as well as nausea and vomiting. The lab findings for Tari disease would be hyperuricemia, that is worsened with exercise, hemolytic anemia, and elevated creatinine kinase levels. The treatment and prognosis here is to avoid strenuous exercise. Consider a high-protein diet. This usually does not progress to severe disability, although a rare infantile form has been reported and is usually fatal. The notes here for Tari disease is that it is more prevalent among people of Ashkenazi Jewish descent. Okay, take a short break. We're going to discuss the next card soon, which will be Pyruvate Dehydrogenase complex deficiency. So think about that for a second. Okay, so let's continue on. We're going to be looking at Pyruvate Dehydrogenase complex deficiency. So let's read the case first. A 4-year-old boy is brought to a pediatric clinic because his mother is concerned about a possible developmental delay. On physical examination, you find the child to have marked hypotonia, an ataxic gait, and chorioathetosis. Ophthalmologic examination reveals poor visual tracking, grossly disconjugate eye movements, and poor pupillary response bilaterally. You order a series of laboratory tests which reveal the presence of a lactic acidosis. You immediately become concerned that this patient may suffer from a defect of carbohydrate metabolism, and you decide to check serum levels of pyruvate to confirm your suspicion. So we're talking about pyruvate dehydrogenase complex deficiency. The biochemical defect here is that it is a disorder that is caused by a deficiency in the pyruvate dehydrogenase complex. This disorder can be inherited by an X-linked recessive mode, or, less commonly, via autosomal recessive mode. Pathophysiology. The pyruvate dehydrogenase complex is responsible for converting pyruvate to acetyl-CoA during carbohydrate metabolism. Because acetyl-CoA is necessary for citrate production, a deficiency in this enzymatic complex will limit citrate production. Since citrate is the first substrate in the citric acid cycle, the cycle cannot proceed. An energy deficit develops in the CNS, leading to neurologic dysfunction. A backoff of substrates also develops, including lactate and pyruvate, and results in lactic acidosis. The clinical manifestations of pyruvate dehydrogenase complex deficiency: you would see progressive neurologic symptoms, usually starting in infancy, but may be evident at birth or in late childhood. These symptoms may include developmental delay, intermittent ataxia, poor muscle tone, abnormal eye movements, and seizures. It is often exacerbated in alcoholics because of thiamine deficiency. And the lab findings would be high blood lactate and pyruvate levels and lactate acidosis. The treatment would be to increase the intake of high-fat foods with ketogenic nutrients. The notes for pyruvate dehydrogenase complex deficiency are lysine and leucine are the two purely ketogenic amino acids, the catabolism of which leads to products that can be used in the citric acid cycle without having to be routed through the pyruvate dehydrogenase complex first. So there we have it, pyruvate dehydrogenase complex deficiency. Take a short break here. The next card we will be looking at glucose 6-phosphate dehydrogenase deficiency. Okay, so let's read the case. A 36-year-old Mediterranean man presents to your clinic with increased fatigue and weakness of 2 days duration. He was recently tested for tuberculosis exposure, and was PPD positive with a normal chest X-ray. He just started an anti-TB prophylaxis medications the week before. On physical examination, he is tachycardic, appears jaundiced, and has mild splenomegaly. You order serum studies which show low hemoglobin, low hematocrit, and elevated indirect bilirubin. You begin to suspect this patient suffers from an X-linked recessive disorder triggered by his current TB prophylaxis, and you decide to consult an infectious disease specialist about alternative regimens that will not cause his current symptoms. So let's think about the details of glucose 6-phosphate dehydrogenase deficiency. The genetic defect here is an X-linked recessive disorder caused by a deficiency in glucose 6-phosphate dehydrogenase, or G6PD. Pathophysiology. G6PD catalyzes the oxidation of glucose 6-phosphate to 6-phosphogluconate in the HMP shunt pathway, while concomitantly reducing NADP to NADPH. Deficiency in G6PD leads to decreased NADPH, a required cofactor in many biosynthetic reactions. NADPH maintains glutathione and is in its reduced form. I'll say that again. NADPH maintains glutathione in its reduced form, which in turn acts as a scavenger for dangerous oxidative metabolites in the cell and converts harmful hydrogen peroxide to water. Patients with G6PD deficiency have increased hemolysis of red blood cells, which rely heavily on G6PD activity as the only source of NADPH for protecting against oxidative stresses. The clinical manifestations. Most patients are asymptomatic until undergoing an oxidative stress. The causes include fafabines, sulfamethoxazole, primaquine, and anti-TB drugs, which results in hemolytic anemia. Patients may also report a history of jaundice, gallstones from increased hemolysis, fatigue, and splenomegaly. The lab findings for glucose 6-phosphate dehydrogenase deficiency would be normocytic, normochromic anemia. And you would see hemoglobinemia, indirect bilirubinemia, decreased serum haptoglobin levels. Peripheral smear shows spherocytes and Heinz bodies. The hemoglobin precipitates within the red blood cells. This is the Heinz bodies. The treatment would be discontinuation of precipitating agent, oxygen, and bed rest. The notes for G6PD deficiency is that it's more prevalent among African Americans and those of Mediterranean descent, and it has been associated with protection against malaria, which is an interesting point. Okay, let's take a short break, and we will look at the next card, which is essential fructosuria. Okay, let's move on with the next card, which is essential fructosuria. Here is the case. A 14-year-old boy presents for a routine physical examination to participate in high school athletics. He has no known medical history, and his family history is significant for type 2 diabetes in a maternal uncle. His physical examination is completely unremarkable. His laboratory studies are within normal limits, except for positive reducing sugar found in both serum and urine. Nevertheless, his blood glucose level was normal at 85. When you inform the patient about this finding, he is concerned about possible diabetes. You assure him that it is unlikely and that further testing will most likely show a benign condition for which he needs no treatment. So this is essential fructosuria. The biochemical defect here is an autosomal recessive disorder caused by a deficiency in fructokinase. The pathophysiology: fructokinase converts fructose to fructose 1-phosphate in the fructose metabolism pathway. The deficiency of fructokinase activity in the liver and intestine significantly reduces the capacity to assimilate fructose into cells. Clinically, patients are usually asymptomatic, and the disease comes to light as an incidental finding. The lab findings would be positive reducing sugar in the blood and urine after meals rich in fructose. There is no treatment. It says that no treatment is necessary. The notes here say that essential fructosuria may be confused with diabetes mellitus if the nature of the reducing sugar in the urine is not defined. So that was essential fructosuria. The next card we will discuss is fructose intolerance. So try to think of a possible case of fructose intolerance. What would you be seeing in a typical case? In this case, a 6-month-old girl is brought to a pediatric clinic because her mother noticed that the baby has seemed lethargic and irritable for the last several weeks. The mother had just begun feeding the baby fruit juices several weeks before this visit. On physical examination, the child is slow in her movements, mildly jaundiced, and small for her age. She also has mild hepatomegaly. You are concerned that the symptoms started after the ingestion of fruit juices, and you order serum and urine studies, which you suspect will show hypoglycemia and fructosemia. While you await the results of the laboratory tests, you tell the mother to stop giving the child any fruit juices in her diet because you believe the patient may be suffering from an inherited enzyme deficiency that alters her metabolism of certain carbohydrates. Okay, some more details on fructose intolerance. The biochemical defect here is that it is an autosomal recessive disorder caused by a deficiency of fructose 1,6-bisphosphate aldolase B in the liver, kidney, and intestine. The pathophysiology: Fructose 1,6-bisphosphate aldolase catalyzes the hydrolysis of fructose 1-phosphate and fructose 1,6-bisphosphate into 3 carbon sugars, and these are dihydroxyacetone phosphate, glyceraldehyde 3-phosphate glyceraldehyde in the fructose metabolism pathway. Let me say that again. The 3 carbon sugars are dihydroxyacetone phosphate, glyceraldehyde 3-phosphate, and glyceraldehyde. Now, deficiency of this enzyme causes the rapid accumulation of fructose 1-phosphate. By sequestering phosphates, fructose 1-phosphate, it says here that by sequestering phosphates, fructose 1-phosphate has a toxic effect on the liver, impeding hepatic function and thereby leading to impaired glycolysis, glycogenolysis, and gluconeogenesis. The clinical manifestations of fructose intolerance is next. Here it says that patients are asymptomatic until fructose or sucrose is ingested, usually from fruit juice, table sugar, or sweetened cereal. The clinical manifestations include lethargy, irritability, jaundice, hepatomegaly, vomiting, and convulsions. And the complications include cirrhosis and kidney failure. The lab findings would be hypoglycemia, fructosemia, prolonged clotting time, hypoalbuminemia, elevated bilirubin, and transaminases. And the treatment is dietary elimination of all sources of sucrose, fructose, and sorbitol. Okay, take a short break here. We have 3 more cards to discuss. Okay, the next card will be classic galactosemia. Here is the case. A 1-month-old foreign-born boy is brought to a pediatric clinic by his mother, who tells you that the child is vomiting after feeding and has been gaining weight poorly. His mother did not receive proper prenatal care, and the child did not have screening tests before or after delivery. On physical examination, the infant is small for his age, appears jaundiced, and has mild hepatomegaly. While normally you would think of possible intestinal obstruction, you notice on physical examination that the child's lenses are clouded, as though he were developing cataracts. You order serum and urine studies, specifically looking for hypoglycemia, galactosuria, and aminoaciduria. You believe that the child is suffering from a deficiency of galactose 1-phosphate uridyl transferase, and that the patient's diet should be limited in intake of milk and other foods rich in lactose or galactose. So this is classic galactosemia. The details here. So the biochemical defect here is that it is an autosomal recessive disorder caused by a deficiency of galactose 1-phosphate uridyl transferase. Galactose 1-phosphate uridyl transferase aids in the conversion of galactose 1-phosphate into glucose 1-phosphate in the galactose metabolism pathway. A deficiency of galactose 1-phosphate uridyl transferase results in the buildup of galactose 1-phosphate, galactose, and galactitol. These substances are toxic to the parenchymal cells of the kidney, liver, lens, spleen, and brain. So clinically, infants present with several nonspecific findings, including lethargy, irritability, feeding difficulties, poor weight gain, jaundice, hepatomegaly, ascites, splenomegaly, convulsions, cataracts, and mental retardation. The lab findings for classic galactosemia would be hypoglycemia, aminoaciduria, galactosuria, markedly reduced galactose 1-phosphate uridyl transferase activity. The treatment would be elimination of galactose from the diet. And some notes here. Neonates are routinely screened for galactosemia. The test consists of demonstration of a reducing substance in urine specimens collected while the patient is receiving milk or formula containing lactose. So that was classic galactosemia. Okay, we have 2 more cards here. The next one we're going to discuss is galactokinase deficiency. A 2-year-old foreign-born girl is brought to a pediatric clinic for a routine checkup. Her mother tells you that the child has not seen a doctor since she was born. The child's physical examination is normal, except for clouding of her eye lenses consistent with cataracts. She is of normal height and weight and has met all of her developmental milestones up to this point. While you ask the nurse to drop a battery of immunizations, you also ask for serum studies, including a serum galactose level. While you await the results of the laboratory testing, you tell the parents to restrict galactose in the child's diet and reassure them that cataracts are the only manifestations of their child's hereditary disorder. This is galactokinase deficiency. Let's talk about the details here. One moment, please. Okay. Galactokinase deficiency. The biochemical defect here is it is a benign autosomal recessive disorder caused by deficiency of galactokinase. As for the pathophysiology, galactokinase is required to phosphorylate galactose into galactose 1-phosphate during galactose metabolism. When galactokinase is deficient, galactose builds up. In the lens of the eye, galactose reductase and aldose reductase convert this excess galactose into galactitol. Galactitol causes the entry of water into the eye by osmosis and leads to the development of cataracts. The clinical manifestations here for galactokinase deficiency would be, in contrast to the multiple organ systems affected in classic galactosemia, infant cataracts are usually the main manifestation of galactokinase deficiency. Patients may also have developmental delays, which are related to sight, such as lack of social smile or failure to track objects. The lab findings would be elevated blood galactose levels. The treatment here is dietary restriction of galactose. Okay, now there is one more card. This will be lactase deficiency. Okay, this last case for lactase deficiency. A 14-year-old Asian American boy presents to a pediatric clinic concerned about diarrhea that has persisted for more than 1 month. He reports that the diarrhea occurs about 30 minutes after he eats a bowl of cereal with milk each morning. He states that the stool are bulky and frothy, but there is no gross blood. He also has a lot of gas and bloating after eating breakfast. He reports resolution of symptoms for the remainder of the day. On further questioning, the patient does not eat yogurt, ice cream, or any other dairy products during the day. You believe that the patient has a common enzyme deficiency and that his intestinal lining is not absorbing an ingested sugar properly. you suggest that he try a commercial enzyme substitute with each bowl of cereal or a different brand of milk that has the enzymes necessary for its digestion. So that was a typical case of lactase deficiency. So let's read the details written on the back of this card now. First, the biochemical defect. This is caused by reduced genetic expression of the enzyme lactase fluorescein hydrolase. Lactase fluorescein hydrolase is involved in the rate-limiting step of lactose digestion. Lactose is hydrolyzed by intestinal lactase into glucose and galactose on the microvillus membrane of the intestinal absorptive cells. Lactose that is not absorbed by the small bowel because of the absence or deficiency of the lactase enzyme is passed rapidly into the colon, thereby leading to the entry of water into the colon by osmosis and the development of diarrhea. Clinically, after ingestion of lactose-containing products, for example milk, patients have diarrhea, abdominal pain, and flatulence. Stools are often bulky, frothy, and watery. The treatment here is reduced dietary lactose intake, commercial enzyme substitute, and alternative calcium and nutrient sources. And lastly here, for lactase deficiency, the notes say, this common problem has prevalence of 10% to 20% among Caucasians, 80% to 95% among Native Americans, 65% to 75% among African Americans, 90% among Asian Americans, and 50% among Hispanics. So we read quite a lot, and I hope that you were able to take in some of that information regarding carbohydrate metabolism. I know for me, it was challenging to read all of these cards, pronounce things correctly, and understand what was being said, but I'm sure that I picked up some important points, and I hope that the same was true for you, and I thank you for joining me on Med School Radio.